So if you noticed, I only spoke about the biology, about what goes on there, because realistically, it's not like a non-steroidal or a steroid knocking out pain. But
Yeah.
what it does improves the area. So say someone's come in with a contusion of their knee, their big swelling, an acute injury. Because it's so good at lymphatic drainage and stabilizing the cells and getting rid of that swelling,
Mm.
a lot of the pain mechanoreceptors is reduced. So the person is less painful and it allows that tissue to start healing more rapidly. So with a big bruise or a really bad swelling on the knee or the ankle, can bring that down very rapidly. Conversely, on the opposite scale, where you're talking about some of the neuropathic pains or the osteoarthritis, you can work locally or on the spine, and you can help those cells on reducing some of the pain and inflammation by stabilizing in the joint some of the inflammatories and making it a nicer environment. So it's less antagonistic of the nerve endings. Whilst if you really have someone with a neurological problem, you have to be realistic. You're going to treat them maybe 10, 12 sessions, but you can actually stimulate the nerve cells to form new junctions and more dendritic outgrowths. So you can actually get them to go and have both a motor function improvement, but also a new pain pathway, so that someone who's got fibromyalgia or a peripheral neuropathy, you can start to make them feel actually better and better sensation.
That's incredible. So there's so many ways then that clinicians can use this within their clinical practice.
Yeah.
There seems to be a big movement lately from away from hands-on treatment as much. When I qualified, it was all very much you spend the entire time with your
Absolutely.
hands on the patient. And the more and more new clinicians we get coming through, my younger ones, they very much have a balance now, which is great. So for the younger ones that are very rehab based,